Welcome back, our fans. Dental management of cancer patients. A patient having cancer is treated by one or more of the following modalities. 1. Surgical treatment. 2. Chemotherapy, causes neutropenia. 3. Radiotherapy. 4. Biological targeted therapies, medications that target certain pathways in the tumor cells only, not in normal cells. 5. Hematopoietic stem cell transplantation, HSCT. 6. Bone modifying agents. Treatment side effects. But these treatment modalities cause some unavoidable oral complications that may be severe enough to affect the patient's life. At this stage, cancer treatment should be interrupted. And so, the prognosis of the treatment is worsened. Oral complications of cancer treatments. 1. Oral mucositis. 2. Stomatitis, aphthous-like ulcers. 3. Infection. A. Fungal infections. B. Viral infections. C. Bacterial infections. 4. Oral pain. 5. Salivary gland hypofunction or xerostomia. 6. Taste alteration, dysgeusia. 7. Halitosis. 1. Trismus. 2. Osteonecrosis. A. Osteoradionecrosis, ORN. B. Medication-related osteonecrosis of the jaw, MRONJ, 10. Graft versus host disease, GVHD. Basic oral care. Routine care performed before, during and after cancer therapy to prevent and reduce the severity of oral complications. So, avoid interrupting cancer TTT. Section Education of the patient, the family and caregivers of the expected complications. Section Regular oral assessment. Section Eliminate sources of trauma. Section Eliminate pre-existing infections, decontamination, dental, periodontal and mucosal. Why acute professional scaling and subgingival debridement. Why acute toothbrushing with a soft or ultrasoft toothbrush 2 to 3 times daily. Why acute dental flossing in a traumatic way once daily. Why acute fluoridated toothpaste. Why acute fluoride application using fluoride tray if high caries index. Why acute antiseptic mouthwash, 0.12% chlorhexidine gluconate. Why acute restorative treatment of carious lesions. Why acute endodontic treatment or extraction of cases of pulpitis. Why acute extraction of hopeless teeth at least 7 to 10 days pre-cancer TTT. Section Oral hydration to reduce the risk of friction and traumatic injuries. Why acute frequent sipping of water. Why acute mouth rinses, as much as needed. 1 teaspoon salt plus 1 teaspoon baking soda plus 1 liter of water, decontaminates, hydrates and neutralize pH. Why acute saliva substitutes, mouthwash, spray or gel. Why acute lubricating the lips to avoid crusting and ulceration. Why acute pharmacological stimulation of residual salivary gland. Section Pain management. Section Early diagnosis of emerging complications. Section Adequate management of the detected problems. Oral mucositis. Inflammation in the oral mucosa secondary to cancer therapy. Cancer therapy impairs the blood supply to the oral mucosa. So, it gets atrophied. The condition is worsened by the neutropenia caused by chemotherapy. Section It allows secondary infection of the lesions and retards its healing. Section It may be source of a systemic infection. Oral mucositis clinical stages, erythema, ulceration, necrotic ulcers, and then healing after stoppage of cancer treatment. It reaches the stage of ulceration at week 2 after treatment, and heals after 4 weeks of stopping treatment. Management, based on the 2019 guidelines. 1. Intravenous keratinocytes growth factor 1 KGF1, palifermin, for prevention. 2. Topical use of honey. 3. Topical morphine 0.2% mouthwash. 4. Oral cryotherapy for prevention sucking ice cubes before and during the treatment sessions to cause vasoconstriction and prevent the chemotherapeutic agent to reach the mucosa. 5. Basic oral care including the saline and sodium bicarbonate mouthwash. 6. Benzytamine mouthwash, anti-inflammatory, is effective in prevention, but chlorhexidine is not. 7. Pain control using systemic narcotics. 8. Nutritional support. 2. Stomatitis, aphthous-like ulcers. Section arise due to oral mucosal toxicity secondary to targeted cancer therapies. Section clinically similar to aphthous ulcers and does not arise on the keratinized mucosa 2. Appear after few days of the first cycle of therapy. Section managed like aphthous ulcers, topical, intralesional or systemic steroids depending on the severity of the lesions. Eye infection, secondary to bone marrow suppression. A. Fungal infection. Predisposing factors, xerostomia, antibiotics administration. Types of candidosis occurring in cancer patients. Pseudomembranous, erythematous, chronic hyperplastic, angular colitis. Management. Topical antifungal, nystatin or amphotericin rinses 4 times/day. B. Viral infection. Section reactivation of viruses, herpes simplex, varicella zoster, cytomegalovirus and Epstein-Barr virus. Section prevention of HSV by prophylactic thymidine kinase inhibitors, acyclovir. C. Bacterial infection. Acute flare-up of dental, periodontal and periapical infections. Bacterial silodinitis of major salivary glands. Management. Section mechanical plaque control. Section fluoride supplements to prevent dental caries. Section broad-spectrum antibiotics. 2. Oral pain. Caused by both mucosal irritation, nociceptive, and neuropathic pain. Mucosal irritation is treated as oral mucositis. Neuropathic pain is treated by NSAIDs. In more severe pains, it can be combined with opioids. Topical anesthetic rinses can be used. 3. Salivary gland hypofunction/xerostomia. Severe decline in salivary secretion occurs after the first week of treatment. Section continues to decline to reach scarce amount at the 6th week. Section continues to decline till 3 months after stoppage of treatment. Section may recover within 1 to 2 years. Section xerostomia is the most common late adverse effect of cancer therapy. Section causes discomfort, inability to swallow, affects food intake, high risk of caries, oral candidosis and increased mucosal sensitivity. Eye dysgeusia. Alteration in taste sensation occurs due to toxic effect of treatment on taste buds, salivary gland hypofunction or oral infections. It may become permanent. 2. Halitosis. Caused by local factors, poor oral hygiene, oral mucositis, candidosis, periodontal infections and salivary gland hypofunction. It may have systemic causes as diseases in gut, liver, kidney and upper respiratory tract. Reduced by O. Basic oral care. O. Mechanical tongue rinsing. O. Antiseptic mouthwash. 3. Trismus. Surgery and radiotherapy causes fibrosis of the submucosa and TMJ. Radiation-induced trismus can start any time after treatment, even years after stoppage of treatment. Prevented by daily exercise of TMJ. 4. Osteonecrosis. A. Osteoradionecrosis, ORN. It is bone death secondary to radiotherapy. It manifests as non-healing area of exposed bone. Mandible is more common than maxilla. The patient is at lifelong risk for the lesion. Prevention by comprehensive oral and dental care before radiation therapy and close follow-up afterwards. Management depends on the degree of the lesion's severity. O. Mild lesions, conservative treatment with antibiotics. O. Advanced or refractory lesions, surgical removal of necrotic bone sequestrate. B. Medication-related osteonecrosis of the jaw, MRANJ. Bone death secondary to administration of bone-modifying or anti-angiogenic agents. Bone-modifying agents are medications taken to reduce bone resorption as bisphosphonates. MRANJ is diagnosed if the following 3 criteria exist. 1. Current or previous treatment with a bone-modifying or anti-angiogenic agent. 2. Exposed bone or bone that can be probed through an intraoral or extraoral fistula in the maxillofacial region and that has persisted for longer than 8 weeks. 3. No history of radiation therapy to the jaw or metastatic disease to the jaw. Prevented by pretreatment oral and dental evaluation and care. Caries, pulpitis and periodontal diseases should be managed before treatment. Management depends on the degree of the lesion's severity as ORN. Eye graft versus host disease, GVHD. A complication commonly occurring after hematopoietic cell transplantation. The transplanted immunocompetent tissue tries to attack the tissues of the host as it recognizes them as non-self. Middle. Chronic GVHD may cause O. Oral lichenoid reaction with or without desquamative gingivitis. O. Sjogren syndrome-like reaction, keratoconjunctivitis sicca syndrome, or O. Scleroderma-like reaction, with limited mouth opening and tongue movement. Middle. C. GVHD affects at least one organ of the skin, mouth, eyes, gut, liver, lungs, genital organs and joints. Middle. When the diagnostic criteria of CGVHD are not totally fulfilled, acute GVHD is diagnosed. Middle. The oral manifestations may be the first symptom of the disease. Middle. CGVHD is managed using systemic immune suppressives. Middle. Symptomatic management of oral lesions. O. Lichenoid reaction is managed using topical steroids. O. Xerostomia is managed by oral hydration and pilocarpine. Thanks for watching. Support us by likes and subscribes.